you can see here, which is going through which the contrast is going into the bladder. So this patient has a rectourethral fistula, and as the surgery was planned and they were trying to do the ileostomy reversal to relieve the previous surgeries and to, give the patient another chance. But when they saw this, they stopped the surgery because it would require an extensive surgeries, both to close the fistula's communication as well as extensive surgeries to treat the high type of anal atresia. So also, I would like to stress on the additional findings, like whenever you are presented with this kind of scenario that they're showing you a fluoroscopy film or a video, then it's a particular case. So there always has to be additional findings with it. So whenever you are suspecting anorectal malformation, anal atresias, always try to look for the additional findings. Tell the examiner that I would also like to exclude the other possible abnormalities. You already know that Bacterial is a very renowned association with these kind of pathologies. So try to tell the examiner that I would also like to search that. And then I would like to move to the discussion into the MDT, and then further decision will be made by the surgical team. They want to intervene or they don't want to intervene. Okay, so previously we also used to do these type of X-rays. This is called invertogram. This is an older way. Sometimes they can also show you this type of image, but I haven't seen in the recent exams they are showing this. Now, these days, they are showing the prone cross table lateral view. I will show these two images in the next slide. And then again, it is important that you tell them the additional findings if there are any. So this is the old invertogram in which they just put the baby upside down and they put a skin marker to the dimple where they suspect that there is a possible anal opening. And then we measure the distance from that skin marker. If it is more than the bowel gas going to the lower part of the pelvis is more than 2 centimeter, reaching more than 2 centimeter of that skin dimple, that means it's a low type of anal atresia, but falling short of that 2 centimeter means it's a high type of anal atresia. This is the horizontal being thrown cross lateral view. You can see very clearly this is the dimple and this is the skin marker. And when we usually during the fluoroscopy, we also try to take some control films, and the pubococcygeal line is a very good marker to tell it's a high type of anal atresia or not. You draw a line and from the coccyx to the pubis, and then you can tell whether the bowel loop is lying, the last opacified, gas opacified bowel loop is up or below that line. If it's up, that means high type of anal atresia. If it is down, that means low type of anal atresia. Okay, so candidate 1, let's move to the next case. Are you ready?
Yes.
Okay, case number 2.
2 months old, 2 months old with repeated UTI.
Okay. So I will just click the play on the video. Just try to summarize your findings in your mind, and then you can start speaking, okay? Okay, try to tell me the name also.
Yeah. This is the sign view of cystography in a 2-month-old with history of recurrent urinary tract infections. I can see that there is a catheter in the urethra with a contrast being injected inside the urinary bladder. So I think this is a micturating cystourethropy. Upon injection of the contrast passes into the lower part of the left ureter, which appears to be dilated. And the right ureter was not outlined with contrast. So here I'm suspecting left side vesical ureteric reflux. I would check the entire series to trace the contrast column, whether it reaches the renal pelvic calcium system or not, as will change the grading for me. and this images the ureter has some tortuosity in its mid part. So if the contrast reaches the pelvic calyceal system and there is dilatation and clubbing of the renal calyces on the ipsilateral side, so this signifies the grade 5 vesicular reflux with dilated and tortuous ureter. So in my routine practice, I would compare with the previous studies if available, and would recommend an ultrasound for evaluation of the renal size and cortical thickness. These patients need referral to the pediatric surgeon for further evaluation and management. Also, evaluation of the renal function and possible scarring from reflux can be done by DIMSA scan.
Okay,
And
very good.
management is
There is one
by,
additional finding which I want you to pick it up. Okay, I will play the video once more.
I think that there was a diverticulous outpouching near the
Very
vesicular
good,
junction.
yes.
Yeah.
Okay, so here is the diverticulum. Okay. About this case, the importance to include this case is that sometimes vesicoureteric reflux is part of the examination. And what I want you to do is that try to grade it, because in the normal routine, when you are reporting these kind of films, the primary physician always want you to grade these. Okay. So I would, candidate one, can you grade it for me?
Yes, the ureter is dilated and tortuous. However, I cannot see the contrast reaching the renal pelvic calyceal system. So,
Yeah. Okay.
uh,
So what? Yes.
well, grade 1 is reflux into the lower ureter only. And the grade 2, when the contrast reaches the renal pelvic calyceal system without dilatation.
Okay.
If there is mild dilatation of the renal PCS, this will be grade 3, and moderate grade 4, severe grade 5.
Yes. Okay. So in this case, as the film quality was not that much good, otherwise I would have zoomed in the images as well if they were to be spot films. The contrast was actually reaching into the pelvic calyceal system, so we labeled it as a grade 3 reflux. Okay. I want you people to note down the additional findings when you get such a fluoroscopy film, because sometimes the reflux can be associated with other pathologies as well. Additional pathologies could be the abnormal insertions of the ureters, could be anatomical location of the ureters, could be duplex collecting system. It could be very low insertion with the fistulous communication. So all these things, they usually present in a similar manner, and try to see that if there is additional uretroceles or there are like a diverticulum, as in this case, there was a Hutch diverticulum. So these findings are also important when you are presented with such cases in the exam. They will get you very good marks. Why it's important to grade the reflux? So for this, I would like to people, yeah, you can go through this topic, which is the management screening of primary vesicular reflux. It is a guideline which is provided by the American Urological Association. In pediatric setting, it is particularly important that we don't image the babies again and again because of the dose limitations. Okay, so when to intervene with the imaging, when to do the nuclear medicine study, and when to do the ultrasound to check for hydronephrosis, it's very important that you go through these guidelines. The important step, like the important outline of the guidelines is, especially my concern is when you are dealing with a grade 1 to 3 reflux. Okay. So in 1 to 3 reflux, there are like, especially about the grade 3 reflux, as in this case. So there are two options. Either you can put the patient on follow-up, or you can describe the findings to the primary physician and he would take over the decision, and depending upon the clinical condition of the patient, that is the patient stable, patient is septic, patient is having recurrent UTIs. So after that, or the patient bladder is getting affected, like he's about she or he is about to lose control of the urinary bladder because of repeated UTIs, then this is indication of surgery. So anytime during the follow-up, which is usually about 6 months, if the baby present with these findings, then the surgeon knows that he has to intervene and he has to do the surgery. And if the baby is not presenting with recurrent UTI and baby is totally fine, there is no problem with urination, then you can follow it up. The first follow-up is in the 6 months with the ultrasound, and the second follow-up is another 6 months. And after 2 years, this reflux goes away on itself. Okay, so it is particularly important in terms of management that you know these things. I haven't shown you the nuclear medicine study, which is usually MAC3, which is done in the cases. Why we prefer that study over the fluoroscopy or repeated fluoroscopy is the dose limitations, because fluoroscopy, cine fluoroscopy adds a lot of dose to the patient. If the patient is having recurrent UTIs, you can read about the NICE guidelines and you will get to know that how to follow these patients for the nuclear medicine study. And that will guide us more about, like, if the patient is having a structural abnormality, anatomical abnormality, which could be the cause of recurrent UTI and reflux in this case. And there are multiple causes of reflux even. So in this case, as the patient had a diverticulum, so when the patient is having a structural abnormality, then this means that this patient can have complications in the future. So it's better to take a urological opinion. So we did take a urological opinion in this case, and the surgeon put a bulking agent on the distal left ureter, and the patient was like followed up, and she was totally abnormal. Sorry, totally normal. Okay. So the additional findings, which I have already told you, it's important to find out what is the cause of reflux, particularly in the female babies. In the males, we know posterior urethral valve is one of the most important cause, but in the female babies, it comes with lot of other findings, which could be urogenital. There could be urogenital malformations, like uterine malformations, and then associated renal abnormalities as well. So whenever you are presenting such a case in the exam scenario, don't give this, don't let the examiner tell you that you didn't tell me the additional findings, because they are waiting for you to say all these things. And whatever time you have, you can just describe the findings, describe the grading, describe the management, and then move that I would also like to check for the additional findings, and they would be happy about it. Okay. So now I would like to take the candidate number 2. Candidate number 1, you performed very well. Your fluoroscopic knowledge is very good. So I feel like you have a lot of experience in the fluoroscopy. Is it right?
Yes, almost.
Yeah, it's very good. Okay.
Thank
Best
you
of
so
luck for
much.
your exam. Yeah.
Thank you. Thank you.
So can we have candidate number 2? Okay, somebody is asking me to repeat the management. Yes, the management depends upon the clinical condition of the patient. If the patient is having grade 1 to 3 reflux, we usually follow up. Okay, after grade 3, we take the opinion of a surgery, like a urologist or a urological surgeon, to tell us that what to do in this case. I have shared these guidelines because they are followed internationally, particularly when we are going to do the follow-up in a particular case. But overall, if the patient is stable and there is no clinical indication of sepsis, or the patient is not having recurrent UTI, then it can be followed up till 2 years, only grade 1 to 3. If the reflux is more than grade 3, that will definitely need surgery. So the follow-up is important in this case. That was my whole point, that you should know when to follow up with the baby, because we are subjecting to additional doses. Sometimes we are doing ultrasound, and if the things are not clear on ultrasound, we move toward the cystourethrogram. So in order to avoid the dose limitations, it's better that we know the clinical condition of the patient, have a good discussion with the primary physician, because sometimes they are suspecting that the patient is having a recurrent UTI, or patient cannot tolerate any more infections, and they also develop antibiotic resistance with repeated UTI because we give them a lot of antibiotics. So it all depends on the clinical condition, but usually grade 1 to 3 is follow-up, and after 3 we do the surgery. Okay, so okay. Okay, I will try to go slow through the key points. Candidate 2, are you with us now? I cannot listen to candidate 2.
Yes, I am here.
Okay. So I would move to the next case.
A 5-day-old newborn passed meconium once nostril passage. After 3 days, control film showed dilated bowel lobes.
These are the spot films, okay?
Yes. This is an radiograph, plain radiograph of with contrast of an infant with enema, showing there is a small featureless right descending colon is smaller in the caliber with no يعني the hostra is not so clear and no passage of the contrast to the transverse colon. Here is passing the contrast to the transverse colon and to the ascending colon with some filling defect within the contrast scene. It could be due to meconium is within the bowel. Features are of small colon.
Okay.
Otherwise, there is no signs of pneumoperitoneum, and there is no signs of the air within the wall of the bowel, which indicating of ischemia, and the skin bone look normal. The lower part of the chest clear, and the sign is indicative of meconium immature colon.
Okay.
There is some structure at the right side here. No, but there is a passage of the contrast.
Okay. So I want you to say the exact words.
Yes.
What do you think this is?
Meconium ileus.
Yes. Okay. What will you do next?
We try to manage the patient.
Yes.
I think the contrast itself is a part of management of this situation.
Okay.
And we called the pediatrician about the situation.
Okay. So what will you check in the history of the patient?
Post-death.
Yes.
We're asking about the post-death, the post-death of the infant.
Okay. And what particular association is important in this case? Association I'm talking about.
Association. caused it premature rupture of the membrane.
Good.
Inhalation.
You mean to say any NICU setting injury to the lung, right?
Pardon?
Or any other, I am not able to get your point. Aspiration of meconium, right?
Yes.
Okay. But we are talking about the bowel. We are not talking about the lungs.
Yes.
Okay. So it's okay. This case was meconium ileus. What I wanted to stress about is this case was shown to me in my exam in the Viva setting. Okay. We are sometimes very much stressed out in the exam. So the basic things or the basic pathologies which we should have a command on are actually we just neglect them. It is a very common observation in the Viva presentations. So this is a meconium ileus, and you saw that lot of focal small filling defects were noted in the microcolon. So I would show you again, yeah, multiple palettes. And when you observe very clearly, you would see that they are changing their position. Okay. For example, on the right side, they are here, on the left side here, but on the other films, when we saw, they were in the different locations. See this one here, because we are giving a therapeutic intervention to the baby. The water-soluble contrast is therapeutic. So all these pellets are going to flushed out. And if the baby passes the stool on the table, that means that the meconium ileus is relieved. Okay. So this is particularly important when you approach such a case, when you are going to conclude in your report that the baby passed the meconium on the table, because that will tell the primary physician that the baby did get a therapeutic management as well. Okay. Now, I would like to stress on the other differential, which could be meconium plug syndrome. So it is very confusing sometimes to differentiate between both of them, but there is a particular point which I would like to show you people through which you can, feel a difference, that you can make a diagnosis of meconium ileus easily. The meconium plug syndrome is usually the small left-sided colon. And the filling defects or the pellets, which we see in the meconium plug, they are larger in size, and they are very, because it is of a sticky meconium, so they are confluent, they are connected with each other, and they put a long segment of a filling defect in the bowel. So I would like to show you this one, this spot image. This image, you can see that there is a lucency, which is tubular. It is long segment and almost filling entire the length of the left-sided colon. Okay, so this is a case of meconium plug syndrome. And you can tell the similar points to the examiner that, and when the meconium comes out, the sticky nature of the meconium also makes it more likely that this is a meconium plug syndrome. Okay, the next point is that what kind of management you would advise to the baby who underwent the barium enema study and passed the stool on the table. So what will you tell the primary physician? How will you convey this to the primary physician?
In this case or in meconium ileus?
You can tell about this case also. In this case also, baby passed the stool on the table.
I think both of them is relieved interventionally due to contra.
Yes, exactly. So be confident about it. When they're going to ask you, you should say that it's relieved because the baby passed the stool on the table. Why I'm emphasizing this point is that in my Viva setting, they kept on asking that what if the baby couldn't pass the stool on the table? What is the next step in the management? Okay. So what kind of answer would you like to give to that?
Pardon? If it not relieved by the contrast, do you mean? What
Yes.
the next step of management?
Yes.
We can try again another trial.
Yeah, very good.
another trial we can do with them, and
Yes.
IV fluid, nothing by mouth, until it relieved, I think.
Yes. So excellent. So you will convey this that we try to relieve it, but it's not relieved, and they can, wait for about 6 to 7 hours until the baby passes the stool and there is no further abdominal distension. But if the baby is again having abdominal distension and it is not relieved, and you tried once, then you need to intervene and try once more to relieve this kind of, ileus in the baby setting. So now, if I give you this scenario that you did the baby again, and the baby was able to pass the stool on table and it was relieved, but after a week, the baby presented again with the similar complaint, then what will you do?
Um, If we examine the patient first, if there is no risk of perforation, I think we try again after 2 weeks.
Yes, okay. So we can try again after a week also. If the baby is presenting with the same complaint, we can try again for the enema once again. But if the baby is presenting with you about more than 3 times, and it is the same complaint, the baby presents, you give the the water soluble contrast, but it is not relieved, then we need to tell this to the primary physician that they should consider other possibilities as well. Other possibilities of a small microcolon or other things is that you need to exclude the total colonic atresia, you need to exclude the ileal atresia, and you need to exclude the total Hirschsprung disease. So this
Yes.
is important when the examiner will ask you that if the baby is presenting again and again, and within 3 weeks she has presented about 3 4 times with the same complaint. So what are you going to do? We are going to suspect another kind of pathology, that the baby might be having some other pathology. So what will we do? We will check for the ileal atresia. We will give the oral barium. We'll see if the small bowel loops are also dilated. Also, an X-ray can help us see that there is any dilatation of the small bowel loops or not. Because if ileal atresia is suspected, that means the small bowel must be dilated. We need to exclude that. Then we need to exclude the total colonic Hirschsprung disease or the total colonic atresia. And for that, we need to arrange with the surgeon or with the primary physician the need to do the rectal biopsy. Okay, so this case is done. I have shown you one case or two cases.
One case, I see just the meconium ileus.
Okay, then we move to the next case. This one, which we have covered. Okay, one thing which we missed is the cystic fibrosis, which is the most important association. And if the examiner asks you, then you need to speak up about it as well. Okay. Case number 4 doesn't have any history. Okay. I would like to give you the age of the baby. You can say it's 3 months baby.
3 months. This is a fluoroscope of a 3-month baby. Showing there is a contrast a regular contrast is accumulated at the lower part of the, I think, is esophagus, because I see the chest rib, the ribs.
Okay. Is it esophagus?
I see the ribs. These are the ribs behind the contrast, I think. This is an stomach, sorry.
Yeah.
The fundus of stomach passing.
Okay.
There is a dilatation of the irregularity and dilatation, I think, of the stomach, and there is also a small amount of the contrast passing to the duodenum with a narrowing segment of the pylorus, I think, here. This could be a pyloric stenosis.
Okay, try to rethink what you are saying. Is the contrast opacification of this proximal bowel loops is like normal? Do you think it's in the normal location?
It passing from the stomach, passing to the pylorus, and then to the first part of the duodenum.
Yeah.
Second part of the duodenum.
So what is happening after the second part of the duodenum?
There is a stricture, I think, of the second part of the duodenum.
Yeah, I'll show you one more image.
This could be malposition of the bowel. The junction of the
Excellent,
duodenum.
very good. Yes, yes.
The junction of the duodenum with the jejunum is to the right of the lumbar instead of to the left side.
Yes. Okay. Now we move to this one is the last film.
I think this is a malposition of the bowels. The small bowel is becoming to the right instead of the left to the lumbar.
So we call it malrotation, right?
Yes.
Yeah, malrotation. So what do you know about malrotation? Do you know the embryology which is associated with it?
During the embryonic period, the bowel become outside of about 10 weeks, become outside of the umbilical, is a physiological hernia. They should be rotated 70 degree about the axis of about their axis. If this rotation is not done very well, it will result in mal rotation.
Okay, good. Okay, so all of you must be well familiar with the malrotation. It's a very important exam case because it can be associated with a volvulus that would come in the acute emergency finding, and the examiner would try to, test your safety findings as well. So something about it is like you need to know the pathology as well. Usually what they ask is that what is the diagnosis here, and it's very typical on the films which I have shown. But some background is also important. So regarding embryology, what is important is that when the vascular axis is formed and when the bowel is rotating, some of the segments of the bowel, they can rotate abnormally around the vascular axis. Okay, the vascular axis is usually SMA and SMV. So what happens is that if the baby is able to get its bowel rotated to more than 180 degrees, but still some part of the bowel is to the right of SMV, and some part is anterior to the SMA, that means the baby is still having some malrotation. And the important thing to differentiate is it from the non-rotation. Okay? Intestinal non-rotation is something in which all of the small bowel is to the one side of body and all of the large bowel is to the other side of the body. How it happens is that the pre-aortic axis is to the right of SMV, but the post-aortic, like the post-SMA part of the bowel is actually to the left. So what happens is that the rotation is abnormal. The rotation is even less than 90 degrees. So that makes this an intestinal non-rotation. And it's an important differential to make it when the examiner will show you this case in terms of CT, because all of these details you might not be able to see on a fluoroscopy film. On fluoroscopy film, what is important is that you tell the examiner that the patient is having malrotation. The next thing is that I am considering that as the baby is having this background pathology, so if the baby is clinically fine and I do not feel that the baby is having a volvulus, which could be an acute emergency. So in this case, there was no volvulus, but the examiner knows that you are going on the right path. You're trying to exclude the acute emergency finding, not to miss it. And what about the next step in management? It also depends on the patient. Okay. If the patient is fine, you can take an outdoor surgical opinion. Why we need to send the patient to surgery for malrotation is because of the risk of volvulus. Okay. So you need to tell the examiner, I will refer the patient to the surgery, and they will do the CT scan and they will check the degree of rotation, and also they will try to evaluate the patient on clinical basis, and then they will decide about the further management. Okay. On ultrasound, SMA and SMV axis is usually shown by the examiner. The case will start from the ultrasound and then it might move to the fluoroscopy. So you need to be very well familiar with the ultrasound images as well. And what is more important is that which of these pathologies is more prone to complications. Malrotation is usually more prone to complications, and the acute one is volvulus. And on CT, if they show you the CT of a baby, which is less likely because in pediatric setting, we try to avoid the dose. So they might not show you any CT scan, but if they show, you should know that the duodenal-jejunal junction is usually inferior to the duodenal bulb. The bowel might not reach the vertebral axis on the opposite side of the body, like to the left side of the body. And the normal vertebral level of the duodenal bulb is L1 and L2. So if they show you typical, very limited images of the CT, you need to see the position of the duodenal bulb. Is it at the same vertebral level, like L1, L2? And what is the position of the duodenal-jejunal junction if they are showing you on the coronal view with respect to that duodenal bulb? Okay, in that case, you can tell the examiner that this is a malrotation case. Okay,
Can I
so
ask?
now, yeah.
Can I ask? If we have a good experience handed ultrasound, can we ask about the CT if we diagnose the case by the ultrasound and with a good experience doctor? Can we need CT for more characterization, or is enough to diagnose and then the management in the case of
Uh,
malrotation?
Yeah, in case of malrotation, it actually depends on the primary physician. Like, what does he want from that case? Sometimes
Mm,
they don't want to do further imaging in the baby and they will just send the patient to the surgery. But sometimes the surgeon says that I want to see how much degree of bowel is malrotated. Okay. So in that
mm,
case, you might not be able to tell the degree of malrotation on ultrasound, even if you are a very good sonologist, you might not be
mm,
able to tell exactly. So in that case, it's better to do the CT scan and see the vascular relation with respect to the bowel and then describe it in your CT report and they will be able to do the surgery as required. Okay.
yes, thank you.
Okay, so you have seen two cases and now
Yes.
I would take the messages in the chat after finishing with this candidate. Okay. Now case number 5.
3-month-old with the drooling of secretion. An X-ray of the frontal chest X-ray of a child. It shows there is a dilatation of the right mediastinum, widening of the right mediastinum, extending um, up to the neck, and there is a soft tissue density extending from the neck tail to the right side of the heart. There is no evidence of
So which soft
pneumothorax.
tissue? This one? You're talking about this one?
No, this one, which you know, this. Excuse
Okay,
me.
just ignore it. Yeah, it's just ignore it because the baby's neck is like down when they are performing the
But there,
X-ray. So this
I
all
think
shadow
there is.
is for the neck. Yeah.
There is a widening of the mediastinum, of the right side of the mediastinum, with
Okay.
the chest tube is seen in sight. This is
Okay.
inch tube, I think.
Yes.
Yes.
This one.
Yes. And there is no evidence of the pneumothorax. Both lung fields are clear. No shifting of the mediastinum. The bone, there is no evidence of any fractures or bony lesions. I think just there will be a widening of the mediastinum.
Okay. What about this?
An endotracheal tube.
Can you see these two metallic clips?
Yes.
So what do you think is happening to the patient?
It could be a previous surgery done for him.
Yes. Yes. You also saw the chest tube.
Yes.
Okay. Now going back to the history, 3 months old with drooling of secretions. Yeah. So you should make up your mind that the baby is having some kind of surgery with drooling of secretions. There is also one PICC line catheter, which is here, which you might
Yes.
not be able to see very well because the film is not that of a good quality. Okay, so this is the next, like the same continued part of this baby.
This is a barium swallow of the 3-month-old child, showing there is a narrowing of the upper part of the esophagus,
Okay,
and passage. There will be passage of the contrast to the stomach, but there is some bubbles are seen within the upper part of the contrast, and I think there is a strictures seen at the upper part of the esophagus.
okay. So did you notice that the contrast is given orally and
Yes.
the NG tube is still in place, but the contrast is not given through the nasogastric tube? Okay.
Yes. But
So,
it not
yeah. So why would the doctor want us to do that? Like, why not use the NG tube? And you also saw
maybe
the surgical clips.
maybe the baby was of tracheoesophageal fistula. No, they sent for the imaging to know the success of the treatment of the management, to see the success of
Yes,
the
very good.
management.
Very good. You are on the right track. Yes. Okay. So you saw that there is some kind of narrowing here in the
I think
mid part of esophagus where the surgical clips are there, right? And there is
yes,
proximal dilatation.
yes,
And these motor lucencies are because some of
of
these,
the oral, yes,
yes,
of
they
suction
are
of baby.
being collected there. Exactly.
Yes,
Now I'm going to move to the next. Okay,
this
there
is
are some other views. Yes.
yes, this is an oblique view, I think, and AP view of the swallow. It shows the same structures seen at the mid part, at the side of the clips of the esophagus. So I think there is a success procedure, but somewhat structures uh, occur at site of surgery.
Okay. So
But
even if it is within the 2 weeks post-operative period, you want to say that this can be within the expected post-operative findings, right? Because they have operated there, they have closed communication, and there are some surgical clips over there. But when you observe on the fluoroscopy study is that the contrast is smoothly passing, and there was definitely no communication, right?
yes, but
Okay.
يعني, there is no contrast passing to the tracheal and to the
Yes.
to the tracheum bronchi, passing the contrast from the esophagus to the stomach. It means a successful
Surgery. Okay.
management. There is no evidence of any fistula
Okay.
or
So,
still communication.
okay, this case is continued, and they presented again, like the parents of that baby took the baby again to the primary physician, and they are saying this to him, that the baby is unable to tolerate the feed and is vomiting since last 2 weeks. So we have performed some additional study. These are the images.
Yes. This is a barium follow through showing there is somewhat dilatation of the upper part of the esophagus, and barium swallow and follow through, showing there is dilatation of the upper part of the esophagus, but passage the contrast is to the small bowel, reaching to the small bowel. But I think still the position of the small bowel is not is accumulated all of them to the center of the center part of the abdomen. I think it could be enlarged liver. Yes, could be an enlarged or ascites pushing the bowel to the center. Something is.
Okay. So do you think that the view is in entirely AP, or do you think it is an oblique view?
Is AP.
Okay. So it is slightly oblique. I would not say entirely a good AP view, but this is slightly oblique because, see, this part of lung is, you can see more, and this is very less visualized. And you can see
Yes.
even the tilt of the pelvic bones, that there is some kind of tilt. The baby is tilted. So that means it's not an entirely AP projection. There is some kind of oblique view, but this is ignored. This is normal. Okay.
Yes.
I need you to focus on the pathology, that what was happening previously to the baby and what is happening right now.
Hmm. There is no passage of the contrast to the stomach. Where is the stomach? Just I see the small bowel.
Okay, so the nasogastric tube is little bit, ahead of the stomach. That means it might not be, it might not be pacified by contrast. This is the next film.
There is still there is a dilatation of the upper part of the esophagus. Could be and the passages of the contrast to the trachea, to the right side of the trachea and bronchi, pacifying the trachea and bronchi. It means that there is a fistula.
Okay, so where this area you are suspecting?
The other film. The other film, yes,
This one?
there is there is a dilatation of the esophagus and passing of the contrast through the trachea and bronchi. I see pacification of the.
Okay. So initially, about 2 weeks before, when this baby came, we performed the first study, and we concluded that the surgery was successful. And
Yes.
now this is the after 2 weeks, the baby presented, and we have done some of the study, some of the fluoroscopy study again. And now we are saying that there is something wrong with the baby. Okay. So what is happening is that they did repair the tracheoesophageal fistula, and there was no immediate residual fistulous communication. But when the baby presented again after 2 weeks, the baby is having vomiting and drooling of secretions. That means that the fistula, which was initially repaired, it is not, there is some kind of abnormality associated with it. So we tried to do the study and ignore the nasogastric tube. So just when the baby is drinking, you can see there is extreme dilatation of the proximal part of the esophagus. And there is some bubbly secretions as well. And when the contrast is about to opacify the distal part of the esophagus, it is actually not opacifying the distal part. It is creating a communication with the tracheobronchial tree. So in the previous film, when we go back previously, uh, in this one, you could see that even with the dilatation, the distal part of the esophagus was still opacified. Okay. But when we
Yeah.
move to this part, we can see that because of the communication, all the contrast is now going into the tracheobronchial tree and it is not opacifying the distal esophagus. So that raises a suspicion there might be a residual fistulous communication or the tract is not mature enough. And this is leading, like this is causing an aspiration in this baby. So we raise the suspicion of both the scenarios that there could be a possibility of a residual fistulous communication, and there could be a possibility that this could be an aspiration because the proximal esophagus is extremely dilated. So some of the secretions might spill from the upper part of the trachea and go into the tracheobronchial tree, although less likely, but we did raise the suspicion. So the doctor contacted us and he decided that he would redo the surgery. And when he did the surgery again, he found that there was some fistulous communication. So the baby was subjected to a repair again. Okay, so your radiological findings are very important when you are dealing with a particular case which has a lot of, background history and which you do not expect complications, but they do get complication later on. So previous history and imaging is very important. What about the further management in this case? As we raised the suspicion of a possible fistulous communication to the surgeon, and he did the redo surgery, and then it was found out that there is a residual communication. Now, important thing is which contrast media to be used. So what do you think that we should be using?
Low osmolar contrast media, because the if we use the gastrographin, it may cause pulmonary edema, so we cannot use it. We should use low osmolar contrast media. If we use the barium, we there may be uh, a fistula with the lower part of the esophagus, so we afraid peritonitis. So the best thing here, the best contrast here is the low osmolar contrast media.
Okay. Okay, so you are saying that we should avoid barium because it can cause mediastinitis, and we should use the low osmolar contrast, a water-soluble contrast, right?
Yes, water soluble low osmolar contrast media.
Okay, good. This question was asked in the exam setting multiple times, what kind of contrast media you will use when the patient is post-operative. So the easiest way not to go into the details of what kind of contrast media is there, it's iodinated, not iodinated. They just want to hear that you say a water-soluble contrast media. Okay, that's more than enough to conclude the case because you
Yes.
are going, you're trying to avoid the complications in the baby, which is already having a lot of post-surgical changes in the chest. So you will say that what soluble contrast we will use. Okay. So, okay, candidate number 2, you did very well. Best of luck for your exam. Just try to be confident. You take your time in
Okay.
the films, but try to be confident. And then, inshallah, you will do very good. Okay.
Thank you. Thank you. Inshallah.
Okay. So I would like to go to the chat. First of all, let me see if there is anything there. Yes. Regarding this case first, please show malrotation case by again. Okay, I will show it again. Contrast three small bubble loops in the later film. Or you're talking most likely about this case because the NG tube, which was positioned in the stomach, was actually going into the small bubble. So that's why when the technician injected the contrast, it reached the small bubble. So okay, about the stricture and fistula closure, yeah. So there was some kind of narrowing in the post-operative films, as we saw. But in the lateral views, it was very clear that the narrowing is opening up and it is leading to the continuous passage of contrast through the post-surgical tract. So it was not labeled as a stricture. I don't know what about your saying contrast, intravasation, aspiration, or intravasation. When we talk about the bariums, we only deal with the aspiration. I don't know what you mean by intravasation. If you can put it clearly, then I might be able to understand your point. There is the cobra head in the left image. That was just the gas bubbles. Okay, because when the baby drinks milk with the feeding bottle, there is some kind of gas bubbles you will see on the films. Okay, again and again, I'm getting requests for malrotation. So I would like to show that case once again. Okay, regarding the classification of the fistula, we try to avoid to do that. Okay, because the primary physicians they don't like it that we classify it on our films. And in this case, we didn't have the preoperative imaging available. It was done outside. The surgeon was from outside, but the patient when performed surgery and the parents noticed that it's not improving and they wanted to check, so they referred the baby to our hospital. So we didn't have the preoperative imaging. Otherwise, I would be so much happy to show you guys the preoperative imaging as well. And regarding the classification, we try to avoid that. Okay. Because sometimes people have different opinions on different type of classification, and the surgeons, especially in Saudi Arabia, pediatric surgeons, they don't like that we should classify which type of fistula is there. Okay, so we try to avoid putting that in our reporting PDFs. Okay. So now I would like to show you people again, once again, the malrotation. Yeah, this one. So these are the targeted fluoroscopy films, and you can see that the nasogastric tube was reaching the stomach. There was initially, it looks like there is some kind of narrowing in the body of stomach reaching the pylorus. And then as the candidate said that she was confused, maybe there is a stricture there. But whenever you're doing fluoroscopy, it's always a continuous series of images. So when you take the series of images, then the diagnosis gets very clear that there might not be any stricture. And especially when I'm showing you these cases, and the contrast is pooling to the one side of the bowel loops. It's not going to the other side. The bowel loops are basically immature. When we deal with the babies, their bowel is little bit immature. So it takes some time that they get distended when we are giving the contrast. And once they get distended, then the contrast passage through rest of the bowel is also shown in the films. So in order not to make a hurried up diagnosis that there is a stricture there. So try to think about the scenario that it's a baby, the bowel might be immature, and on the subsequent films we saw that that part of narrowing is also getting opacified by contrast. Like here, initially we thought this is the stricture, then the opacification of contrast is there in the proximal part of the small bowel as well, in the duodenum first part as well. So try to think the scenarios which are actually related with the patient you are dealing with. Okay, so hypothetical scenarios is not possible. I'm not saying that the stricture or fistula in this age cannot present. It might present, but think about the common presentations first. Okay, So if the baby is having, I didn't give any history, but if the baby is presenting with these findings, it might be diagnosed outside, not in my hospital. But you can tell on these images that there is some abnormality regarding the bowel loops. The small bowel loops are coiled up on one side of the abdomen. The duodenum, we expect the third part and DJ to cross this midline, move to the next, move to the left side, but it's not crossing it. It's just giving some angulation, but when it is reaching the vascular axis, which is most likely in the midline, it's just not going to the other side. It's staying on one side. Okay, that raises the suspicion that this is a case of malrotation. Okay, whenever you're confused or you think that there can be a possibility that this can be intestinal non-rotation, first of all, examiner will not show you a case of intestinal non-rotation on fluoroscopy. It needs, because they are less symptomatic, the patient might go to the adult life and they might present with appendicitis later on, which might be missed because usually the appendicitis is not right-sided. In that case, it will be left-sided. Okay, so it's a less likely possibility they will show you a non-rotation case. But if they do show, do remember that the axis in the center is the point which tells that the patient is having a non-rotation or intestinal malrotation. If you see some kind of angulation is there, the bowel is twisting and moving, trying to move to the central part of the body, but still remaining there. That means it could be a malrotation case more likely. Okay, so I need to move to the next candidate. Who is candidate number 3?
Assalamualaikum.
Alaikum assalam. Okay, so you are candidate number 3?
Yes.
Okay. Okay, candidate number 3, case number 6.
So this is a 3 weeks female baby with repeated UTI. So this is the spot image of a retrograde urethrogram in which I can see that contrast is seen of pacifying the urinary bladder, which appears normal. No evidence of any diverticularly or any abnormal tuberculation seen. No evidence of reflux of contrast seen in this image. Bowel loops appear normal. I could not see any other abnormality. I would like to see if there is any other image of this study available. So on lateral image, I can see that the contrast is seen passing into the passing posteriorly into the outpouching, likely representing vagina, in keeping with vesicovaginal fistulous formation. No leakage of contrast is seen. No evidence of reflux seen in this image. So I will inform the pediatric surgical team about my findings and further management of this case.
Okay. There are some more images. Now you can see that in this image, the catheter is removed.
Catheter is seen, removed. So I think that this is post micturition film.
Yeah.
In which I can see that the contrast is passing out of the urinary. This is urinary bladder, or I think this is the pouching in which the contrast was seen, vaginal pouch.
Yes, so there is some retention of contrast, right?
Yes, there is some retention of contrast noted.
Okay. So what is your final diagnosis?
So final diagnosis is vesicovaginous fistula with retention of contrast in the urinary bladder.
Okay, so you did say this is a vaginal canal, right?
Yes, I think this is vaginal. Yes, this shape is same like vaginal canal. Yes.
Yes. Okay, so there is retention of contrast over there. That further strengthens your diagnosis.
Yes.
Okay.
Yes.
Yeah.
Yes.
Okay. Okay. So very good, candidate number 3. Interpretation is very important. Why? Because whenever you are going to perform any cystourethrogram studies, you need to have a very clear knowledge where the catheter is being placed, and if you see any other abnormal contrast opacification, then it means that the baby might be having fistulous communication. It could be with the bowel, it could be with the bladder, and it could be between the bladder and the vagina. So it could be within the ureter even. So try to, try to think about it in a way that you are putting the catheter in one organ, like in the bladder, and if another organ is getting contrast opacification, so that means it is not a it is not a normal anatomy of the normal anatomy we expect in the patients. Okay, so in this case, what about the further management? Candidate number 3, can you tell us that is there any role of MRI in such cases?
Yes, we can perform MRI to rule out associated uterine anomalies or renal anomalies because it is associated with ectopic urethra duplicated collecting cisterns and other uretrovaginal anomalies.
So especially in the female babies, it is important to rule out the associated urogenital anomalies. Okay, and they might also show you that if it is a long case, they might also show you an ultrasound image. Okay, where one kidney might be present, the other might not be present. Okay, they might also show you an MRI image in which you might find a rudimentary horn of the uterus or a unicornuate uterus, because there are a lot of associations. Syndromes are also associated with it. You can read about them, because if it comes in the long case, even if in the long case I'm talking, then it might be good to read about the associated abnormalities which can be associated with these babies. Usually in the long case, they try to show you the additional abnormalities as well. In one of my cases, they did show me it was a renal agenesis case, and they didn't show me one kidney. Okay, so in the back of mind, when you are in the examination setting, uh, you might not think about checking all the images of the ultrasound, like have they shown you liver? They showed me liver, gallbladder, pancreas, kidney, but they didn't show me the other kidney. Okay, so it is important to think on that line as well, that have they shown you complete abdominal images? What are they expecting from you? So if they did show you one kidney and they didn't show you another kidney, and it's a baby, then immediately think that the baby might be having renal agenesis. And then all the associated findings could be a long scenario in that case also. Okay, so I'm going to show you the next case, case number 7.
Okay, 84-year-old man with symptoms of GERD. So this is the frontal and lateral plane radiograph of an adult male patient, in which I can see that there is paraesophageal elongated structure is seen, could represent dilated esophagus.
You talking about this?
It can be unfolding of aorta, or it can be this one.
Okay. It's okay. Or any other finding?
There is some radiodensity opacity seen here, but I cannot appreciate any this corresponding opacity on frontal radiograph. Bilateral apices clear. Lateral radiograph.
Okay, so the patient presented with dysphagia. What are you going to do next?
Next, barium swallow.
Okay.
Or contrast swallow, yes. Okay. So there is a large contrast fill pouch is seen in the proximal thoracic inlet. I could not see any passage of contrast beyond this. So I will like to see the other images of the study if the contrast passes or not. So there is a large contrast filled outpouching is seen posterior to the esophagus, best seen on this lateral radiograph. This likely represented a Zenkus diverticular. So I will assess its size and size. I will measure its size and neck, and then yes, I think it is slightly below the level of Killian's diverticulum. So I refer the patient to GIT surgical team for likely endoscopic diverticulectomy of this patient. Okay, so this is the post-op image of this patient, in which I can see that metallic clips are noted in the proximal thoracic inlet. I will like to see the fluoroscopic images if available. So contrast is seen passing through the proximal esophagus distally. I could not see any abnormal stricturing or stenosis or leakage of contrast. A streak of contrast is seen passing into this bronchi, could represent aspiration. I will check if there is any other lateral imaging available to see if their diverticulum has been excised completely or not. Yes, this contrast is seen passing into the chest. It could represent the formation of post-op fistula or aspiration. So I think this is contrast is seen passing into trachea, likely to represent tracheoesophageal fistula's formation. So I will advise CT abdomen with oral contrast for further delineation and urgently refer the patient to surgical team.
Okay, so I'm stopping here. So you can see the two tracts which contain the contrast. Okay,
Yes.
one is the trachea and one is the esophagus. Okay, other than this, which is the epiglottis. Okay, do you find any other fistulous tract between them?
No.
Yes. So what is happening? What is happening is that what I'm trying to show you here, let's see the swallowing mechanism. Okay, this is the epiglottis, which is covering the trachea, and there is slight delay when the patient is trying to swallow and move the contrast through the larynx. You can see that the epiglottis is there to cover the windpipe, but the movement of this epiglottis is not rapid. Okay, it's little bit delayed, due to which you see a lot of contrast going into the trachea. So this is aspiration, but in this case, this is a post-operative case. What happened to the patient that he's having this kind of aspiration? Because the cause of aspiration, if we saw the previous images, we have already removed the diverticulum. Okay?
Yes.
They removed the diverticulum. You couldn't find any fistulous communication, but the patient is still having aspiration. And the patient is 84-year-old. Okay? So what could be the possible causes of this reduced motility of the epiglottis, which is covering the windpipe? Can you think of any cause?
Aspiration or motility disorders
Yeah,
or
good.
dysfunction, like age-related dysfunction
Yes.
or
Anything else? Anything else? Like which can reduce the neuronal connections or the nerve thing which can cause muscle paralysis or something like that.
phrenic nerve or vagal nerve injury.
Yeah, you're on the right track. You're on the right track. Okay. So it is little bit a tricky case, but what I needed you guys to show you guys is that the epiglottis is covering the windpipe, and whenever the patient is swallowing, the windpipe is not adequately covering it. Sorry, the epiglottis is not adequately covering it, and some of the contrast is seen going into the interior part of the trachea. And there are certain motility disorders which can be autonomic, which can be post-inflammation, repeated upper respiratory tract infections. Okay, but in the old age scenario, always try to think out of the picture. This case is particularly out of the box. Out of the box means that if the patient is old age, try to rule out the possibility of a stroke, okay, which can lead to such kind of appearance. Okay, so there is a brainstem stroke, a lateral medullary syndrome, which is associated with usually associated with reduced muscular supply of the epiglottis because it affects the vagus nerve. And then you see that the patient can be having aspiration. That's why the stroke patients, when they present for any kind of treatment, and if they are showing any symptoms, they always want to rule out aspiration pneumonias. They want to rule out if the patient can swallow properly or not, because if they cannot swallow, they put the nasogastric tube. Sometimes they put the PEG tube, and it is for the post-stroke care. So this is important that sometimes out of the box thinking is very important. And this patient had a brainstem stroke in the past, and he presented that he's feeling that something is not swallowing right, like dysphagia. But this is what we observed on the post-operative films, that he's having a lot of aspiration. And because of that, we went back and checked the history, and he had a stroke, and he had a similar presentation before as well, with a lot of aspiration and aspiration pneumonias. So this can be one of the cause in this scenario as well. This is the video which I would like to show you people that how the normal swallowing mechanism works. So you can see clearly that the food bolus comes here and everything is synced. Like all the muscles of the oropharynx, all the muscles of the larynx, they work in a synchronized manner to push that bolus. The epiglottis immediately covers, but it covers to avoid the aspiration in the trachea. But in the normal mechanism, it covers entirely. In the abnormal mechanism, it cannot, like it might be weak, it might not cover entirely, as in this scenario as well. Okay, so next case. Yeah, about this case, the Killian dehiscence is the area which is the area of muscular weakness, and usually Zanker diverticulum arises from that area. The important difference is between the pulsion and the traction diverticulum. The pulsion diverticulum, they lack the smooth muscles, so they cannot completely empty themselves, but they do completely empty, but they cannot completely do so. Usually, all the diverticulums commonly presenting in adult patients are usually pulsion diverticulums. The traction diverticulums are usually associated with scarring, with granulomatoous inflammations, and even if malignancy is suspected, then it can also present in this manner. And if the patient is having autoimmune diseases like scleroderma, any other problems, then this can also cause diverticulum formation. Then about the management, as the candidate 3 told us very clearly that the surgeon will remove the diverticula, that is called diverticulectomy. In the 86-year-old patient, why it is important is because malignancy and squamous cell carcinoma is usually associated with it, 0.3 to 7%. And then the cause of aspiration, always try to think out of the box in this scenario as well, that the patient did have surgery, we removed the diverticulum, but the patient had persistent aspiration. And in this scenario, it was a stroke case, okay? So last case for candidate number 3.
So this is 10-month-old baby with abdominal pain. So these are spot images of grayscale ultrasound at the level of bladder and kidney. I can see gallbladder increase. Echogenicity is seen surrounding the wall of gallbladder. However, no evidence of any filling defect seen. Kidney is normal in size. Left kidney is also visible. What is this second image? It could represent, this is liver, upper
Yes.
first image. This is liver?
Yes, yes.
So this could represent increased echogenicity surrounding the portal tracts, could represent pneumobilia or pneumobilia or portal tract gas in the liver. What else can we do? Abdominal pain. I will check if there is any other imaging available. I could not appreciate any focal lesion seen. I will try to look at the portal tract to rule out if there is any evidence of any biliary abnormality. Urinary,
Okay, so
yes.
the accentuated portal markings in the liver on ultrasound in a baby is very common, and it's considered to
Yes.
be a normal physiological finding. Okay, so you couldn't identify the abnormality of these images. I will show you further images.
Okay. So there is increased thickening of pylorus. Increased pyloric wall thickening is noted. I will measure it and I will like, this is splenic flexure bowel. Okay, so there is, I think there is telescoping of bowel loop with concentric bowel wall thickening, likely in keeping with interception. Yes, this is interception with the intervening bowel loops as well as mesenteric fats. I will do the Doppler study to check check its vascularity, and I will immediately inform the referring physician, and I will arrange the pneumatic reduction for this patient. First, I will assess the stability and will rule out any peritonitis or any bowel perforation symptoms in the patient. Then I will do the fluoroscopy contrast, air and pneumatic reduction. And if I fails, then I will advise the surgeon. If the patient is unstable or I fail, or if there is any evidence of pneumonitis or any perforation, then I will urgently involve the surgical team for surgical reduction. Yes, this is the barium enema in which I see contrast is seen opacifying the rectum sigmoid descending colon up to the transverse colon where there is meniscus sign is seen, and the contrast is not seen passing beyond this level, in keeping with previously mentioned interception.
So candidate number 3, what do you think is happening here? You
So there
have
is
given the contrast.
interception.
Yeah.
Yes, there is
You
conopolyp interception.
already you have diagnosed it on ultrasound, right? So
Yes,
you said that we should move to the pneumatic reduction, right?
yes, yes.
So this is the barium enema, and we are trying to reduce the interception here. So see carefully what you can observe.
So now contrast is seen passing through the descending transverse colon, after which there is streak of contrast is passing and no further contrast passage is noted.
Okay, so I told you on the ultrasound images, I actually showed you that there was a segment of bowel which was telescoping at the level of splenic fracture. Okay, so this
Yes,
is the claw sign of the interception. Okay, and
yes.
if you follow it up, we are trying to reduce it. Okay, so you have to tell me clearly, is it reduced or not?
Okay, okay. So this is, yes, this has been reduced now. Yes, contrast is
Yes.
seen passing beyond this point. Yes.
Okay, so the interception is reduced. Can you tell me that is there any extraluminal leakage of contrast?
Mm. Mm. No, I think there is no extraluminal leakage.
Yes. Okay, good.
Yes.
Very good. Okay. So this is a case of interception. The only study point here to show you people is that it's a very important case in terms of exam. It can be shown in lot of, it can be shown on the negative images. It can be shown on the positive images of contrast. It can be shown on the ultrasound. It can be shown on any other imaging like CT, MRI. It's very common to show this case, but you need to go through all the modalities on which it can be shown. Okay, So in this case, we already knew that the patient has intussusception, and the candidate told us very clearly that what she will do next, she will try to rule out the possibility that the patient is having any free gas, the patient is having any ascites, and if there is no ischemia of the bowel. So everything she will rule out, and then the next step is to reduce the intussusception. Why it's important? Because all these things, they complicate it, and they have a very low prognostic value, because even if you try with those methods, you might not be successful. So there can be absolute contraindications, there can be relative contraindications. You need to know very well about them. So rule of three is, everybody knows about it. We need to do 3 attempts, 3 minutes apart, and 3 feet from the table if we're trying to control the pressure. Methods is, you can do is with the saline on ultrasound, you can do it with the barium. And what about the vascularity and the free fluid, how you can check it? The vascularity, you can simply check on the ultrasound, and also the presence of free fluid around the splenic flexure, around the hepatorenal pouch, anywhere. If you see a free fluid, that will be a relative contraindication for the reduction. That will say that it might not be successful even if you try to reduce it. And you need to convey these findings to the referring physician. Intraluminal pressure is 80 to 100, should not exceed 120. One most important thing is that when you're trying to reduce intussusception, as in this scenario, the catheter was placed here. Okay, so this is the rectum. We place the catheter here, and we try to inflate the bulb, and we try to maintain a pressure. We're trying to, open the barium from the rib set. When the barium is open, it gushes into the bowel with pressure. Okay, so you need to control that pressure. Why it's important? Because if the dilatation of this rectum, and you're trying to do the procedure, and if the dilatation becomes more than 3.5 centimeter, there is a risk that the rectum can perforate. Okay, so sorry. So for that reason, it's important that always to monitor and check that you are not over distending the rectum, because it can lead to perforation that can cause another massive peritonitis, and that can cause other complications in the baby as well. Okay. And then the other things is contraindications, which I have already told you, and we will discuss them further as well. So I would like now to call candidate B to unmute. Candidate 3, you did very well. You are very confident, okay? And you just need to observe all the findings, take your time, and you need to present them in front of examiner. You try to, connect the dots, and also try to think out of the box, because sometimes the cases are not very direct. But if you, you try this thing, that you can, obvious finding can be there, try to find the other findings as well, because that will give you some extra marks. Okay, so you are really very good candidate, and I wish you all the best. Candidate B. Candidate B, are you there? Somehow candidate A. The claw sign, I'm in the chat now. The claw sign shows that there is telescoping of the bowel, which we already saw on the ultrasound. Okay, so that means when one part, the you can see the intussusception and intussusception. So when you see the intussusception inside the intussusception, it usually telescopes. So that gives you the claw sign. Okay. Telescoping not in the picture, it was in the ultrasound, the transverse view, maybe not very well seen, but it was on the ultrasound transverse view. And yeah, bowel obstruction is contraindicated for pneumatic reduction. I would tell you about these relative and the absolute contraindications. So not on the fluoro. On the ultrasound, yes, I showed you one of the, I will show you once again. There was one transverse view, but it was not very, yeah, this one. You can see this one was taken in the transverse view. This is the outer part of the bowel. This is the inner part. But because of maybe the ultrasound image quality, you are not able to see exactly. But the inside was very hyperechoic, then hypoechoic, and the outer wall was hypoechoic. Yeah, it should be stopped if you suspect that the rectum is dilated more than 3.5 centimeter.
Hello,
Yes. Are you candidate B?
I'm candidate 4.
You're candidate 4. Okay. 1 minute.
E, can you unmute yourself? I don't see any mic with candidate B. I think she has some problem. We can go to
Okay,
candidate 4,
so
ma'am.
okay. Not in this case. Hirschsprung disease is not associated with this case. Okay. Let me go to the other cases.
I'm candidate B.
Okay. So, what do you think, Mr. Irfan? We should take the candidate B now. Candidate B, can you be more clear? Because I cannot hear you.
Ma'am, I'm here.
Okay. Okay, so candidate 4, you will be after candidate B, okay?
Okay.
So this is case number 9 for you, candidate B.
Okay, ma'am.
Can you read the history?
Yeah, 56-year-old patient with dysphagia.
These are the spot images.
Okay, so I've been presented with barium images of this patient who is complaining of dysphagia, and these appear to be oblique and lateral projections to me. And here I can see that there is mucosal irregularity, mainly involving the mid-lower esophagus. There is, however, no obvious stricture which I can see in the images which have been provided. There is no dilatation or pooling of contrast seen anywhere. So these mucosal irregularities, this can be due to tertiary contraction since the patient is elderly, or another possibility which I'm thinking of is can be because of diffuse esophageal spasm.
Okay.
So I'll
Anything
like
else?
to see nut track esophagus.
Okay. Try to give me some more differentials. So the history is 56-year-old patient with dysphagia.
I'm not able to see any obvious stricture. I can see some small outpouchings in the lower esophagus. So this can be due to esophagitis.
Yes, could be a possibility because it's old age. So what do you think about these irregular indentations on
Okay,
the...
so this can be intramural pseudodiverticulosis.
I don't see any tiny diverticula, but okay. Anything else?
Because of mucosal irregularity all throughout the course of the esophageal lining, I'm thinking of some esophagitis, maybe viral or candida.
Okay, so what would you like to do?
In case it's candida esophagitis, I'd like to know the state of the oral cavity whether the patient is a known candidiasis patient, which has led to this degree of involvement in the esophagus. And
So you would like
besides
to know
that,
the
I would
history.
like to know the immunocompromised status, whether the patient is diabetic.
Okay. So you would like to know the history. And in terms of imaging, what would you do in terms of imaging? If you are reporting it, what would you check first?
Any endoscopy or any biopsy, which might have been done for this patient,
Okay. Or any previous?
or any previous record, yeah.
Yeah, very
Previous
important.
image. Yeah.
Yes. Let's go see.
So these are the previous images.
Yeah, you can read the film. There is a date mentioned there.
Okay, so this is 22. So I think this is the previous one. Okay.
Yeah.
So here I can see that again there is mucosal irregularity seen in the lining of the esophagus, mucosal lining of the esophagus, and this seems to have increased in the present scan. Thing. I think.
So why I'm showing you the 1 minute and 2 minute films of the same study from the same segment.
Just to show that there is some reflux which is going on.
Okay.
So can be because of reflux esophagitis.
Okay. Anything else?
I think I can make out. I think besides this.
Okay, it's okay. So going back to the previous film, this one, I will explain it for you, okay? So that you don't miss it in exam. It's very important, okay? So see, this is the barium oral examination, and this is all esophagus. You can see the lumen is opacified by contrast, but there are some continuous tubular filling defect, which is extending throughout the length. And you can see that these filling defects are not exactly through the lumen. They are just putting impressions on the lumen.
Okay, so esophageal varices.
Yes. Okay. So these are the esophageal varices. And why I'm showing you the previous film is that previously the patient had varices and he did some fluoroscopy study and they did the cine. So on 1 minute and 2 minute, they saw that this filling defect, which was only at the gastroesophageal junction before, this was getting filled up with the contrast, and because the vessels, they change, they distend, they contract, they vasodilate during the study. So they were appearing and then they were going away. Okay. So that's the most important thing to check in this case, that this filling defect, which is shown here, is actually later on it's becoming filled with contrast. Okay, and it is not an outpouching, it is not a diverticulum. It was just an indentation on the stomach wall. So when the vessels they relax, the stomach walls become dilated with contrast. When they constrict, they put pressure, and it becomes the impression becomes more prominent on the lumen of the esophagus. Okay, the best film is this one. Okay, you can see continuous tortuous long segment filling defect throughout the length of the esophagus. Now, as the patient is old age, what would you like to exclude in this scenario?
I'd like to exclude cirrhosis in this patient.
You will go to the history, you will ask the patient, is
Yeah.
there any previous history or anything else, 56-year-old, based on the imaging findings?
Any history of hematemesis for which the patient might need interventional intervention in the form of ligation or sclerotherapy or banding. in case
Yeah,
the patient has
in terms of
hematogenous.
management, you're right that from the previous imaging, if we compared, we can saw that they are increasing. Okay, so they are definitely increasing. So the patient must need some kind of management for that. But in the old age, and you're sitting on in your office and you're watching this barium study, and the patient is 56-year-old and is complaining of dysphagia. So the first thing which should be in your mind is that you need to exclude malignancy. Okay. So in this case, as these were varices, what is the differential of varices?
Varicoid C.
Yeah, varicoid CA. So why I'm showing this case, again, the importance of the case, it came in the exam. And as you are trying to, make differentials and consider different pathologies, and you're trying to make up your mind, I just want to tell you that keep open ears when the examiner is telling you something, because they already know that the case might be tricky for the candidate. Okay, so they want to give you clues. So listen to those clues. They might say that the patient has previous history of cirrhosis. Okay, or they might say the patient had previous history of liver disease. Or they might ask you that what are your thoughts that the patient is in the old age, so what would you like to exclude? So in this case, it was uphill varices, and because of the portal hypertension, patient had, they were increasing, and the patient, because they put pressure on the lumen of the esophagus, the patient was having dysphagia. Now, when we saw the barium examination, we really couldn't exclude the possibility of CA, especially in this case. See, the lumen appears to be very irregular and tortuous, although it is throughout the length. But as it's in the old age, we really couldn't say that this is just because of varices. So the patient did endoscopy, and it was found that there is no malignancy. So this case was only for varices, but you need to exclude varicoid CA in the old age. And when you will say that I would like to exclude it, then your next step, which you just told me, would come in handy. You will tell the examiner, I will do the endoscopy. I will advise the endoscopy. I would advise the histopathology. And you would tell exactly everything that if it comes out to be malignant, I will discuss this case in the MDT and everything. Okay. And if there is no malignancy, then the varices obviously need treatment. You will send to the hepatobiliary MDT. They will discuss what to do with this patient, and they can decide about the banding or whatever they want to do, keeping in view the other comorbidities of the patient. Okay, so I will move to the next case.
So this is a 76-year-old female patient with complaints of food being stuck after eating.
So these are a couple of videos.
So
So are you able to see anything?
yeah, I'm seeing AP projections, frontal projections of the barium swallow of this patient. We can see that the barium is passing normally through the esophagus and is seen entering the stomach. Can I see the lateral projections also?
Okay.
Okay, so now I've been provided with the lateral projections. Not able to see much. Maybe there is a focal bulge in the esophagus, in the middle.
Okay. What do you think?
There's a focal bulge, contour bulge in the esophagus in its middle third. This can
Okay.
be because of traction, tractional diverticula, or I would like to see any previous record, previous details of the patient for this, if there was similar bulge previously also, or because otherwise I don't see anything significant in the lungs, any fibrosis. So maybe the patient had something in the past and in the mediastinum, which is leading to some traction and leading to this focal contour bulge in the middle esophagus, and that can be a cause of the patient feeling something like stuck in the throat. So I would like to see any CT which might have been done before.
Okay. No CT is available. Only these films are available. No other comparison.
So there is definitely some contour abnormality in the mid esophagus, and for this I would like to recommend a CT chest for further evaluation to look for any extrinsic cause which might be leading to this appearance of the middle esophagus.
So if there is an extrinsic cause, so why
Yeah.
would there be a focal dilatation?
I was thinking on the lines of because of some traction which is leading to a focal bulge or focal outpouching there. So there can be some nodes which might have healed and then which might be leading to this tractional effect on the esophagus, or it can be simply a diverticulum.
Yeah. So what do you think is the most more sensible thing to say about the traction?
A traction diverticulum.
Yes. You definitely see there is an outpouching there, right?
Yeah.
And there is a contrast level.
Yeah.
So that means there is stasis of contrast in that particular level.
Okay.
So when I showed you this, you can see that here the wall of the lumen is like outwardly extending, and there appears to be some kind of small contrast retention area, but it is not complete. Like it doesn't have proper walls. It is not that particular appearance you see in the Zenker diverticulum, like a full outpouching, like a balloon shaped, and then you see that the contrast is pooling there. It is very subtle. It is very subtle, but still you can see that there is some kind of contrast stasis over there in that particular area. And especially when you go to the other films and correlate it with the other cinefluoroscopy, you can see there is a projection here, shelf-like projection, and another small projection is also there. See this one. Okay, both of them, they demonstrate that there is some kind of contrast stasis, even with the dot, but still you can see that here there is a contrast level and then here is a contrast level. Okay, so you are suspecting that the patient might be having diverticula. Okay,
yes, ma'am.
So now what about like when we consider diverticula, we say that it can be pulsion, it can be traction type of diverticula. These are the most common classifications. Okay. And it is particularly important with respect to I already showed you one case of Zenker. It is particularly important when the patient have any previous TB exposure, any other scleroderma, connective tissue disease exposure, or the patient had any focal infection over there in the past, which healed, and the patient developed this kind of diverticular. So all your thinking was on the right track. You just needed to communicate your thought process. And always remember that the logic, you should always use logic when you are putting the differentials. So if there is a focal indentation from outward to inward on the lumen, it will not cause an outpouching. Okay, it will appear as a filling defect, but eccentric and limited to a wall. Okay, but when you see an outpouching, that means the muscular wall over in that area is becoming weak and it's collecting contrast. So that means that's the definition of a diverticulum. Okay,
Yes, ma'am.
let's move. Yeah, these are the delayed images. Okay, you can see that the contrast in the contrast was there in the stomach and everything, but did you see this?
Yeah, there is some retention.
Yeah, so it is typical that that area was a diverticulum because we were doing cine. It was not entirely, getting any shape as we expect in our conventional fluoroscopy images. But there was a diverticulum there. It had a stasis of the contrast. And as the patient is old age, what was the age? I'm not sure. 76 year. Okay. So at the patient was old age, so we did try to refer her for endoscopy and histopathology and diverticulectomy because all the diverticula in the old age carry a little bit risk of malignancy, which has already been discussed. Okay, so next step in this case, I already explained. Types of diverticula, traction diverticula, usually the examiner shows are the pulsion type. Okay, in my practice, I haven't seen traction diverticula, but I know about them because I can tell that which one is pulsion and which one is traction, because the pulsion would always have a fluid level. Okay, it will always try to attain the shape of a balloon, but the traction is like a focal scarring, a focal irregularity of the lumen, which is in the form of, you can say, a scar. So when you see a scar, the scar has, irregular margins. When you see a scar in the center of the esophagus, getting up the contrast, and it is continuous with the lumen, that means that is a traction diverticulum. And when you say traction diverticulum, then you need to rule out the associated abnormalities as well as malignancy. Okay. So varicoid CA or squamous cell carcinoma can also occur in the traction diverticulum. Okay, so you need to tell the examiner that the first thing is that the patient should have endoscopy, histopathology, and should be discussed in MDT for further management. And if the patient has on histopathology is having malignancy, then it needs to be taken a different path. Okay, so I am left with, I think, one case that's a little bit long case, and I would like to give it to candidate 4, if that's possible. Candidate B, you did very well, but try to be confident about your findings. Try to make logical differential diagnosis, because one aspect of your Viva is clinical reasoning. Okay, so
Yes.
if you will give some differential diagnosis which might be unrelated or which are far away, the examiner might trick you into that, and you will lose your time. You will lose your marks, and you can also lose your confidence. Okay, so
Yes,
try to make some logical differential diagnosis. Always you should be present in that time of Viva. Don't think about the past case, don't think about anything else. Try to make up your mind that you should remain present in that situation and give yourself full attention to what examiner is saying. Okay, sometimes they try to detract also, but it's not the case most of the time. They're trying to help you. Okay, they might also give you clues, but it depends on you that how much wit you have at that time, that you can take over those clues and you can put them into your logical reasoning. Okay, so
yes,
try to see more and more cases. Fluoroscopy is not the all part of the exam. It is just a limited number of cases. So you can practice these cases very well. You can see the typical classical cases, and then when you go in the exam, you will be confident. Okay. These are the cases which I'm showing from the real type scenarios, because the examiners, they are not showing us the bookish cases anymore. They are showing us the cases which might be not a single pathology, which might have a dual pathology or another additional findings. So just to make you people aware of these kind of fluoroscopic images and cases, so that you don't get confused when you present in the real Viva sessions. Okay, so try to engage in lot of discussions with your fellow colleagues about any of the cases, not just fluoroscopy. That will give you more confidence. Okay, best of luck.
Ma'am, was this pulsion diverticulum then? Because it was quite smooth.
Yeah, yes, it was pulsion.
Thank you.
Okay, now I would like to take candidate 4 for the last case.
Hello.
Yes, are you candidate 4?
Yes, ma'am, I am. Am I audible?
Okay. Yes, you're audible. Yeah.
Yeah, I've been presented with a 6-month-old baby with excessive crying. So I've been presented with spot grayscale images of the abdomen of a 6-month-old baby with excessive crying. I can visualize that the liver appears to be normal. The right kidney is focused, and the right kidney appears normal in size. There is no evidence of any hydronephrosis. The pleural space also appears to be normal in these spot images. I also visualize the gallbladder, which appears to be normal. Okay, I've been presented with the splenic spot section. The spleen appears to be normal. However, I appreciate that there is minimal splenic fluid collection noted in the abdomen. I also visualize that there is the left kidney, which appears to be normal, no hydronephrosis, no calculus seen. So I'm concerned about the free fluid which is seen inferior to the splenic. In the region of the pelvis, I appreciate that there is telescoping of the two bowel loops, one within another, with mesentery and mesenteric vessels also telescoping within. This is giving a targetoid appearance and is likely representative of intussusception. This is the sagittal or the transverse section, where again I can see the pseudo-sandwich sign. The mesentery along with its fat and vessels are seen telescoping within the intersusceptions. On color Doppler images, I can see that the bowel wall is showing a maintained vascularity. However, I'm concerned because I could localize some free fluid in the left upper quadrant. And this could be suggestive of impending perforation or impending ischemia. I'll be concerned, I'll be red flagging this case, and I'll be urgently contacting the on-call pediatric surgery team. This will require a hydroscopic. So since I'm concerned of underlying free fluid, I'll want to take a surgical opinion regarding and want to check the clinical status of the patient. If peritonitis is not suspected in this case, then we would go ahead with 3 attempts of hydrostatic reduction.
Okay, so what would you like to see next?
So so this is
as you said, hydrostatic reduction. So
yeah.
I'm just trying to make your scenario more feasible for you. That the next step so please try to explain this. I will try to run the video again and again. Yes.
Fluoroscopic barium enema being performed for hydrostatic reduction. Here I can visualize that the barium is ascending through the rectum, and I'm able to visualize the claw sign at the level of the sigmoid, at the level of the sigmoid colon. However, there is no resolution of the interception in this case on the first attempt. In my routine clinical practice, I'll be reattempting
So I have further a few more images as well.
Sure. So in this fluoroscopic image, also there is progression of the barium level in the sigmoid colon. However, there is no complete resolution of the interception. And in this third sign clip provided to me, I can clearly visualize the meniscus sign. However, the interception has yet not relieved. I am not able to visualize any extra bowel spill of the barium, suggesting there is no rupture. This is the lateral view, where there is persistent visualization of the claw sign, and again here there is no resolution of the interception. However, the barium column is progressing superiorly. And in the last few sign clips, I can see that there has been a resolution of the interception.
Okay.
Could you please-
So yeah, I would like you to see it again and tell me, is there a resolution or not? Because
Sure.
that's the question we are dealing with right now.
Yes. So I'm focusing on the barium column. It is opacifying the sigmoid colon. So there is no free resolution. I cannot see the barium extending freely into the ascending colon. And there is a lot of resistance which is being visualized. And
Yes,
in the
agreed.
last,
Okay.
yeah.
The
So
this is the
in
last
the
image.
last few clips, I do see that there is peripheral opacification of the bowel
Yeah,
loop.
exactly.
However,
Yeah.
the barium contrast has not entered the complete lumen, and
Yes.
that signifies that the contrast is only lying surrounding the endoluminal aspect of the interceptions, and it has not completely resolved the interception.
Yes. Very good. Excellent. Okay.
So,
So
even after 3 attempts, if there has not been any resolution, this will need urgent pediatric surgical intervention, and this will be resolved surgically.
yeah. So one thing I would stress in this case is that always keep your clock ticking, and you have to follow the time limit, which is standardized. Like you should not be giving more than 3 to 4 minutes in this case. And the second thing is that did you notice that the patient had free fluid around the splenic, perisplenic area, right? You
Yes, ma'am.
identified it
Yes,
on the
I
ultrasound. Okay.
had, yes.
Yeah. So this case was actually shared to me by my colleague. And when he did the ultrasound, he was sure that there is some turbidity of the ascites, like here you can see, perisplenic, and that poses a relative contraindication to, proceed for the interception reduction. So he didn't do that, but the patient did get to some other hospital, and it's also linked with our hospital. So we did have a record that somebody tried to perform it there. But when they did perform, they were not successful. Okay. One big thing to notice in all these fluoroscopic images is that there was no extraluminal air. Okay,
Yeah.
there was no extra luminal contrast. Try to repeat these things when you are telling the examiner again and again, because they are the safety findings. Okay, they want to
Yes.
listen to these findings so that they can give you good marks and they can make you a safe radiologist. Okay, so the problem in this case was that the intussusceptum was too long. Okay, so when you have about 7 to 9 centimeter of intussusception, telescoping of the bowel loops, a bowel within bowel, and you are putting lot of pressure, and the rectum is distended, and it is still not, you are reaching your mark of 3 minutes, and it is still not resolved. You should abandon the procedure, and you should tell the surgical team, as you said, so that it cannot be reduced. And the
Is that
prognostic
answer
factors in
correct?
this case. Yeah, and the prognostic factors in this case was that the patient had already turbid ascites. That means the patient had sick bowel. It didn't have like the Doppler looked normal, that we couldn't rule out ischemia in that case. But there are certain findings like the secondary signs which tell us that it's better not to proceed with this case any kind of with any kind of intervention at radiological part, because it might not lead to a success. And even if you try to reduce this large segment of bowel, it might recur, because in some cases the recurrence is about 20 to 30%. So when it is recurring, and this, first of all, this long segment of bowel could not be reduced. Second of all, the patient already had ascites. That means the patient was having some kind of dehydration going into the sepsis, or the bowel might be ischemic. And the third thing, even if you are able to do that, you might get a poor recurrence. Okay. So all these factors tell us that it's better that the surgery should handle this case. And this is what happened. The patient did get laparoscopy, and that segment of the bowel was removed. And luckily, it was not ischemic. Okay. So this was the last case of the session, candidate number 4. You did very well. And I would really want to show you guys more cases, but because of the time limitation, I really don't have prepared right now. But maybe in some other session, we would arrange, I would like to arrange another session for the plain films particularly. In my hospital, we do a lot of plain films. And it's the requirement of the FRCR 2B examination to be very good in the plain films, because of the short cases, and the Viva sessions also start with the plain films. Okay. So I would like to conclude the session. First, I would like to see if there is anything in the chat. Yes, thank you so much for all you people that you were there to attend it. Small and large bowel fluoro, please show next time other diseases. Okay, the fluoroscopy cases which I showed you people, actually this lecture is also, you can say, a sort of repeat, because I already delivered it on another DKT platform for Pakistani candidates. But because of the request of lot of candidates, I delivered it again. These cases are very typical cases. Okay, so don't go after the cases. They cannot ask you more than this, which I have shown you here. Okay, just try to focus, try to see more malignancies. You might not get the fluoroscopy malignancies because UK is like moving to other investigations. Like they want to do the CTs, they want to do the endoscopies, and mostly things are diagnosed over there. The fluoroscopy is like very conventional. But these cases, because in pediatric setting especially, we are still looking at a lot of cases which are coming in the Viva sessions. So that's why I arranged this session. And other important thing is that other type of malignancies or the small bowel diseases can be viewed on other kind of modalities as well. Okay. For example, you can see in these small bowel enterography, you can on the CT, on the MR. So there might not be enough cases, but whatever is shown here, you can get 1 or 2 scenarios in the exam. They do not show atypical presentations. They just want to show that they just want to see your approach towards a particular case, and the cases are not very atypical. I have a particular opinion about that varicose, about the varices case, but because the candidates who did well in those cases, they actually told me that the examiner did give them some clues. So that's why they were able to reach that diagnosis. So just try to make yourself comfortable in the Viva environment, and be respectful towards the examiners. You can ask them again and again, whatever you have your questions. And it will be okay. I'm trying to see if you have any more questions. Please show last case fluoro image explained by you with arrow. Ultrasound is fine, but explain fluoro. Okay, so I will do that. This is the last case. Yeah. So in this particular video, you can see that the segment of the bowel, it was actually a large bowel telescoping into the large bowel. Okay. So what happened is that we tried to reduce the intussusceptum, but it was so long that even if with a adequate amount of pressure and with keeping in view the clock ticking for 3 minutes, it could not be reduced. So this is the telescoped segment of the bowel, which we started pushing from here. It moved here, and then it's here, and then on the other further images, you can see that it moved further. And initially, it was a good news that we are trying to reduce, and it's moving further away. But on this cine, you can see that contrast started to move to the periphery, as the candidate highlighted very well, that the contrast is going to the periphery of the bowel loop. There is some space, but when we are trying to push it, it's not getting reduced easily, and it's still posing a lot of, you can say, restriction. That means that the segment of the bowel is not, you can say, very much, you can say it's inflamed, because that's why the patient is having some kind of fluid in the perisplenic area, as the bowel is not normal. So that's why it's taking long time to move. And when it's not moving, it's causing more restriction. That means that the patient cannot have the intussusception reduction. So that was done laparoscopically to remove, it was about 9 centimeter of the intussusceptum. So the 9 centimeter is a long length to push it, and keep on a check on the pressure and the clock as well. And as I told you in the previous case, that we cannot distend the rectum beyond a certain limit. It has limitations. Otherwise, it can cause perforation, and that would lead to another complication in the patient. Okay, let me go back to the chat. Okay. This is my email address. If anybody of you wants to, about these cases or any kind of discussion regarding fluoroscopy, pediatric fluoroscopy, you have any confusions, you can always try to reach me, and I will try to answer your queries as well. Can you show the second case about the vesico-ureteric reflex? Okay, I'll show it. Bowel that is dilated or rectum or sigmoid. Actually, we could not tell. I think it is still it was still reaching the transverse colon. Even the transverse colon was whole, telescoping into the descending colon, and then it was reaching into the rectum as well, because on ultrasound the focus, the target was seen in the pelvis. I think all of the questions are covered, but one vesico-ureteric reflux, what is best? Yeah, this question is very tricky, pneumatic or saline. Actually, both of these things can be debated. Both of their own have their own advantages and disadvantages. But what I know is that the pneumatic reduction is very rapid, and if the baby is going to have a reduced intussusception, then pneumatic is like preferred, because you can do it within few seconds, as I showed you in the previous case as well. But with the saline, it takes more time, and you get to push more and more, then wait again, then check the bowel with ultrasound, then you need to push more and more. So it's a little bit time taking. But I would not prefer any one of the procedures. It depends entirely on your hospital, that how they are dealing with such cases. If they have the availability of a pneumatic reduction, then it's totally fine. If they want to do saline, then that is totally fine as well. The complications is pneumatic has little bit, because if you're trying to reduce it rapidly, and if there is rectal perforation, then the patient can get peritonitis, and that's a life-threatening complication. Okay, with ultrasound, you are a controller, you can control it. You can check with ultrasound if you see any free leakage or any free gas, you can immediately check it. So it all depends on your technique and your experience regarding handling that cases. So I would not prefer one over the other because both of them can be therapeutic. Okay, I need to show one case which is requested. It was the third case. No, it was not the third case. This was the fistula. Second case. See if I can find it. I don't know where it has gone. Suddenly it has vanished from my screen. Anyway, you can post your question in the chat and I would be happy to answer that. Somehow I can't really find it right now. What contrast use in enema if suspect bowel obstruction or perforation? Okay, in our department, it also depends on the availability of the contrast media, but in our department, we use water-soluble contrast for all kind of barium enema studies. Okay, barium can also be used for the enema studies, but we use water-soluble contrast. If you can tell us one time watching, then it would be easier for us to watch anytime as well. For the repeat telecast, I think. Okay, so best of luck to all the October candidates. And I'm very, very hopeful that it will be a very good result for all of us in the DKT platform. And just try to be confident, try to revise the basics, which we try to divert from them, but try to revise the basics and try to stick to your checklist. That's very important. Okay. And furthermore, if there is any opportunity, I would like to take another session, and that would most likely be about the plain films, the hidden findings, and especially for the short cases, because that has been requested. So I will try to arrange a time and then I will inform the DKT team. Thank you so much and good luck.
Thank you so much, Dr. Anna. The feedback link is in front of the people. You can kindly spare some time and give us the feedbacks. Thank you.
Yes, everyone who is online, please fill the feedback form so that we can arrange further more sessions for you people.